Okay. Okay. Here we go. Okay. Everybody ready? All right, great. Special populations or patients with special needs, challenges. We're going to go through not just any kind of mental deficits, physical deficits, but also people that need the aid of mechanical advantage in all senses of the word. So people that need respirators, that have electronic bypass units, have stomas, and all the other things in between that we go on occasionally. It's not the most of our calls are not these, but we typically go on these calls maybe once or twice a month. And in these cases, it's best to know a little bit about everything. But if you don't know it, ask the people there what it's all about, and like learn as soon as you come across some things, so that you have a lot more knowledge about it the next time you go and see it. But in any case, don't be afraid to ask questions when somebody presents with some kind of special needs. Find out what it is exactly. Talk to the patient, or if you can't speak with the patient, speak with people that are in care of that patient. And so most of the time, well, let's not do most of the time starting off this whole thing. Let's just go through it and see where we're at. I want this to be way down here. Come on, Sally. All right. Is that going to go away? Okay. I didn't pause. Did I mute that? No. Okay, good. Okay. So take this into consideration. You're dispatched to the home of an 11-year-old boy in respiratory distress. Dispatch tells you that the patient is a ventilator-dependent child who has a tracheostomy in place. What are we talking about there? Tracheostomy stoma. If you look, this is a tracheostomy stoma. This is what the back end of an endotracheal tube looks like on the inferior portion. It's got an inflatable bulb, or an inflatable, what do they call that thing? I can't think of it now. In any case, this is deflated, and there's a tube that runs up to this little blue line with on the end is a syringe port. So you fill the syringe with air, you place the stoma in the spot that it's going to sit. And then usually this sits behind either the vocal cords or someplace down into the trachea. You inflate it, it locks it in place, kind of like an anchor. And then that patient is going to breathe primarily out of that main hole there, that tube. So for some reason, you're going on this call and this patient can't breathe. What are some things we need to be concerned with? Right. Exactly. Oh, that's great, Abe. Yeah. We can't use our non-rebreathers. Our nasal cannulas are shot more or less. Even our bag valve masks with the mask don't work on this patient. So anytime, and that's a really good thing to already see, that's heads up to know that anytime we're giving oxygen, you don't put it over the nose or mouth like we always do. We put it over that stoma hole. So keep that in mind. But this is fundamentally an airway and breathing problem that we need to correct quickly. So If that is ever the case, there is a kind of mnemonic that we should be thinking about as we go through all of these. Anytime you're dealing with a mechanical aid for the patient's health, we should go through these steps and thinking about why potentially there is an issue, which is dope. Somebody always inevitably laughs. Dope. Dope stands for, well, you know what it stands for. The other dope stands for displacement. The tube or the portion of it is no longer in the place in the patient's body. There's an obstruction somewhere in the tube or the lining or the kink in the line or whatever happens to be. In this case, what could be obstructing this patient's airway? Mucus. Okay. Pneumothorax, somehow we busted a lung, and that's easy to do with the mechanical aids, especially the older ones were kind of aggressive, barbaric. They're a little bit, they just worked. And if they had a weak lung, if it was a smaller lung, so be it, it popped. There was no feedback to recognize an increase in pressure. So let's say if this thing, if the air is partially filling in a spot in the lung where there's a buildup of pressure, where maybe there's some mucus that stops the exhalation of air from that distal area of the alveoli, you give more air forcefully and you could pop it from the inside out, creating a pneumothorax. The newer ones do have a little bit of feedback loop on, or feedback mechanisms, where if they're meeting with resistance to an extreme level, they'll actually not pump as strongly. And then the machine will usually beep, 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 and let somebody know there's an issue. And then finally, equipment failure. And I mean, what could be all the reasons for equipment failure? There's myriad reasons. Batteries dying, cords been disconnected, the actual electricity cord gets disconnected as well. There's when you put the battery in place, it doesn't hit the terminals. There's all sorts of things that you need to manage. And so this is a lot like, you go over to someone's house as an electrician or a plumber, and they're going, well, our pipes don't work. And you start to troubleshoot things. The only difference is now you have someone's life hanging in the balance. So you have to be able to stabilize ABCs while troubleshooting and finding out all these other issues with potentially what this machine is, what it does, and why it's not working. So in a case of a mechanical ventilator, when patients cannot breathe, and why would that be the case? Can you think of some reasons why somebody could not breathe offhand? We had a big issue with this in 2020. For which reason? COVID. And they're also finding out that did much more harm than good for the majority of patients placed on a ventilator. Yeah. Yep. It's unreal. So what happens is, because you lose your ability to breathe on your own, the muscles can atrophy. The tissue, because you're filling it up to such a high inflation rate every time, it stretches and weakens the tissue inside the lungs as well. And with the addition of having a lot of oxygen in your system, that too can make it cause some vasoconstriction inside the bloodstream, inside the pulmonary system, which could also cause vasoconstriction and cause weakening and loss of blood to the distal areas. Anytime we use a machine to help us with stuff, we lose a lot of the ability to do it on our own. And that's a really dangerous thing to keep in mind. If you suddenly start to rely on even a cane, you lose the ability to keep yourself balanced. You lose the ability to correct if you lose your footing or something. So all of these issues, something even as mechanical as a brace or a walker or something, you start losing the accessory muscles around there so that when you fall, potentially it's much, much worse. So patients with spinal trauma, of course, anytime someone is a paraplegic or quadriplegic, not every time, but in many cases, if it's a high up enough fracture on the neck, like Christopher Reeve, Superman, did you know about him? Yeah, he was riding a horse and fell off and fractured, I believe, C2. So he fractured the area where, as the nerves come through, the one that innervates the diaphragm was broken, was severed. He's no longer able to breathe on with his diaphragm. So you would see him and he would have a trach tube in it. He would talk, and as he talking, you hear him breathe like that when the air would go in and out. And he'd have to time his sentences to make that happen. And you're stuck in a wheelchair, not able to even move or breathe. That's going to be rough on your body. The sedentary lifestyle is really bad for circulation, for the buildup of blood clots, for the loss of strength of breathing. All of those things aid to speeding up your terminal velocity, your death. So it was a massive, well, what they were concerned with is that it was an inflammatory response where your lungs would get so swollen and mucousy that people wouldn't be able to breathe on their own. So what they would do is bring them in, and if they noticed it initially, there's a lot of weird stuff going on with the whole thing there, but when they noticed the patients couldn't breathe, rather than wait for them to go into a respiratory arrest, they would knock them out, intubate them, and then have them basically comatose while they went through the COVID sickness, and they'd wake them up on the other end. A lot of patients didn't do very well. Also, there was a lot of, should I tell you guys the politics of it? You used to get huge grants if you had patients on ventilators. So the more people you had on ventilators, I think it was like a $16,000 or $20,000 grant every time you put a patient on a ventilator for your hospital. There's a lot of fishy stuff going on there. Government, if you need to buy respirators, you need to buy ventilators, you need to have staffed people, we'll give you 20, it might even have been like $70,000 a patient. I'm sure. Yeah, I'm sure it was going through different companies. So a lot of this I mean, seriously, that's the dirt of this government and the way that modern medicine works these days. You think of Jonas Salk, who found the cure for polio and then just gave it out to the world. So I'm not getting paid for this. And he gave the world the vaccine for polio in the 50s. And now these people are like, how much is an EpiPen? $3,000 or something. It's just dirty baseball. Gnarly, man. But in any case, a lot of people went on ventilators, and we're finding more people now have chronic lung issues like your friend's dad than the people that just suffered through the COVID and fought it and dealt with it and took steroids or took some antibiotics or antivirals rather and steroids and kind of toughed it out. So when you go on these patients, be aware of what the position is for them, why they are on the respirator, where they're stationed, where they're located. Sometimes you might have issues, which is not on dope, but it should be one of the P's. If it's a bedridden patient and you're laying in bed often and you don't move your blood around, what could potentially could happen to your blood? Clotting. And then the clot dislodges from wherever it is in your leg, gets up into your chest, into your heart, and out to your lungs. Pulmonary emboli would be another issue. So we have to, at least when we're dealing with breathing problems, remember, listen to lung sounds, see if they're coughing anything up. If the case were that they had a pulmonary embolism, what kind of coughing, what kind of sputum would be coming up? It's pink, frothy sputum, And that's because the fluid starts to build up in the pulmonary blood vessels that fill they swell, and the plasma starts oozing out of the bloodstream into the lungs. And occasionally their holes are big enough that red blood cells are slipping through with it. So it turns pink. It's not bright red, but it would be pink because as those holes get larger, as this whole pipes get thicker, more swollen, the holes open up. And as the plasma is going out, you get red blood cells, white blood cells, platelets along with it. So this is what we consider is what we call a stoma. Every time you do your head to toe, we're looking for the neck is tracheus midline. Do we see JVD? Do we see a medical alert tag? Do we have a stoma? This is what's left over after someone has had a trach tube. Most of the time it heals up. It might cause lasting damage with like speaking and infections and things. But if you're bedridden and you can't breathe on your own, that's what they go with. So can you see where that would basically be here, this port? So you you fit it in the right angle, you drop it down in there, inflate the cuff, and then you have the port right here, which not incidentally, but on purposefully, this is the exact size of a BVM port. So you can hook a bag valve mask directly onto that if need be. Also, this is one of those times where the soft suction, not the hard Yankauer device that we typically use, that big, that crooked, angular, solid piece of plastic, is not going to be as effective as what we call a French or a soft suction. Soft suction is just basically a large tube that's flexible. That's got that same couple of perforations at the bottom. And so you would hook that up to the suction tubing, drop it down through this hole and go down the tube and try and suck out whatever happens to be lodging inside there. And oftentimes that's the case, that somebody's got an infection or they haven't been able to cough anything out, or they cough and it sticks at the bottom of the stoma. So you have to go in and just suck out the gurgly, chunky stuff. Also, think about it. If you're bedridden, you're not moving any of that fluid out of your lungs. That is a likely issue, is like pneumonia or some kind of lung infection. So most of the time that I've been on them, it's not the device that's malfunctioning. It's usually mucus clogging that airway. Okay. Am I going backwards or not? Okay. I did go backwards. Okay. So this is what it looks like. This is how you put it in. This is called a stylet at the very bottom. Basically, you take the soft tubing. It's not as soft as, as that is, but flexible tubing. You place the stylet inside it, and that gives you some reinforcement as you drop it down into the airway. You inflate the cuff, you remove that stylet, and now you have that port. Now you can see in some cases, people will have these either attached to some kind of necklace, like a Velcro necklace. There are times, I don't think they do it with this, but these can also be suturable areas where they can lock it into the side of the neck. When they do central IV lines, they will do something that looks similar to that port, smaller. And when you start the IV, it's got those two little flanges on the side that then you stitch into the skin to keep it in place. Okay, this is what you would do if you needed an Omri breather on the patient. Will these people be able to speak? Sometimes they can. Sometimes they talk like this and they can talk. All right. You've heard of tracking respirations, right? When someone inhales, you try and give them a bag valve mask. You try and give them positive pressure. This was the one time that I really got good at doing it. We had a patient who had polio as a child. He was in his 80s or something. And he couldn't breathe. And so we transported code 3 to Marin General. This is as a reserve in Tiburon. So I connected it up, and the medic goes, how good are you at tracking respirations? I'm like, I've never done it. I said, well, you're going to learn today. So behind the patient, as the patient is sitting in the gurney, you sit in the jump seat, you attach the bag valve mask to the port, and then you just watch their shoulders. Every time they take a breath in, you try and squeeze that bag so that you can help them. And when every time you feel the pressure begin, take the pressure off and just talk to them. How you doing? You okay? Sometimes I'd miss the breath. It takes a little bit of practice, which was good to figure out the timing and just realize you're not going to be perfect at it. But in any case, it was nice. Yeah, you just watch their shoulders. So if they're breathing, now I would give them a breath, you know, because you're sitting behind, holding, attach the back valve mask, the patient's seat, and then you can see the back of the head and the shoulders. And you got the bag valve mask over that way. And every time you see the shoulders go up, you just lightly and press and track that breath. Push positive pressure ventilation in to help with their negative pressure inhalations. It was actually really nice when he got to the hospital. One of the nurses like came over and she knew him. She's like, "How you doing, Jay?" And like went and gave him a big kiss on the cheek and hugged him. It was one of the first times I'd seen it, like, you know, like an affectionate, like, oh, you don't have to be just like a, you know, clerical nurse that doesn't worry about, you know, she was very motherly and affectionate, and it made an impression on me. Okay. So any questions with that? Here's another case. And that obviously just any issues where you are bedridden or you've lost the ability to have nervous connection of your breathing muscles. Oftentimes you'll find patients in that with the stoma. Car accidents even. There's a guy, the actor named Jan Michael Vincent, who had a massive accident and drunk driving, and they went in and he had a stoma for years, and it ruined his speaking voice, and he tried to sue the medic for putting in an intubation tube when he saved his life. Okay, this is muscular dystrophy. There we go. Oh. Thought somebody stole it. This kind of makes me feel like the doctors just got these kids naked and is like, now walk. You know, it's a weird like move. It's a little bit. Nothing. Maybe there is no sound. You'll see. Yeah, he's ripped up, huh? So we'll get into it. This is part of the muscular dystrophy. Loss of muscle strength. Oh. Genetic defect. Yeah. Let's talk about it, I guess.
FSHD is a disease that is severe and affects muscles. It's a crippling disorder and can be very painful at times. Typically, it's diagnosed in the teenage years, so young adults discover for the first time that they have a severe crippling muscle disorder. FSHD, or facioscapulohumeral muscular dystrophy, is so called because it affects the face, the wing bone muscles, and the muscles of the upper arm. And that's often the way it first manifests: an inability to smile, for example, or difficulty chewing because the muscles in the face are not working properly. And then finally, it can affect the strong muscles that allow us to stand and walk, thereby forcing people into a wheelchair prematurely. It's also inherited in a dominant manner, which means that if your parent has it, you have a 50-50 chance of getting it from your parents. In addition, however, up to a third of cases are so-called spontaneous. They had no genetic history of this, and it just appeared out of nowhere. Imagine the horror of discovering that your child, who's been growing up normally, has now developed a crippling muscle disorder that may put them in a wheelchair within a decade or a few decades.
FSHD has been in my family, so I was aware of it. My dad has it, and my auntie and my nana have it. None of those people were particularly affected. So I guess initially I didn't think it would be such a big deal. But I'm one of those people that always thought, oh, that wouldn't happen to me. I'd be one of the lucky ones. I'd be one of the mild ones. So in some ways, I just assumed I'd be mild and I'd just get on with my life. So for the first 10 years, it was really not a big deal. I guess the awakening came after my first child, Ruby, was born, where I had my first really big drop in mobility. And it's really disempowering when you know that physically you can't protect your children all the time. Because there's a lot of things that I can't do with the children. Things, for example, going to the beach. You know, I would like to be in the waves with them. I would like to be running up and down the beach, fossicking through the rock pools with them, and I can't. In our family, we don't plan our future much more than a year ahead. You know, my husband and I don't talk about our retirement dreams because I don't know what they are. So for me, my dream would be to have a cure or a treatment or something that at the very minimum could halt the progress. I can cope with my life as it is now. And look, I'll cope with it however it turns out. But I would just really like to be able to hop into bed at night and say, I don't have to worry anymore.
Everything I do today is around the foundation. I live in the business world, I donate money to the foundation. My life is around the foundation, medical research. So Yeah, it's pretty awful. It's been for the last few years. Well, I suffered from actually after some years of trying to research actually and watching research. I've been disillusioned with progress. And I decided that there's a need to fast track medical research, particularly in Australia, where there was no research. We never had any research until it was established. Also, very importantly, we're creating a real awareness for this actually. And we're creating some real opportunities for Australian researchers to be involved in researching this actually. Well, I think the cure for me would mean that we've made a difference to disease. It's a very common disease. For me personally, I think it's the satisfaction. The reality of the cure on this disease is there's 20 years of very hard work before we get to that point. So the benefits of a cure are for the next generation, but the satisfaction of actually making a difference and making a change.
Not sure if they can test for it genetically prior to showing signs and symptoms. But I would hope that it would be something you could learn about. Okay, let's move on. Okay, let's take a break. Come back at 5 after. All right. So this, we typically don't see spina bifida. This is usually found through sonograms and things prior to actual delivery. Boy, I'm getting super dizzy. Okay. That was wild. Okay, so this is where there is an opening to the back of the dura, and the dura actually never gets encapsulated in the spine, or it can be anywhere on the spine. This is lower down. Sometimes you see it up behind the neck, and it's essentially the dura, the covering, that leather sac around all of the vertebrae, or the spinal cord and the brain itself. So that kind of creates a fistula, and it exposes itself to the outside environment. You can see here in an image. Let me get to the next. I thought I had an image of it. So basically, it comes out the back, and it. Well, I thought I had a better image, or maybe it's in there. So basically, there's just an opening to the outside world where that is mostly CSF, cerebral spinal fluid, floating around. But this then goes up into the brain and the body. So anytime you have an exposed issue, that can cause massive infection and damage to the patient later in life. This is usually managed as soon as the baby is delivered, or maybe even in utero if they catch it then. And what they have to do is a big, long, extensive surgery to go in and kind of either place a lot of that back into the spot that it needs to be. If it's a large amount and there's actually nerve bundles and things, the issue is that you can lose nervation to your legs and the rest of your body. So you can have disability depending on the extent of that. And that's it, pretty extensive right there. That's a profound spina bifida. So they go in and they surgically fix all of this, either by removing the excessive areas and putting it all back together, or by placing some of the herniated tissue back into the body. Let's watch a quick video.
Spina bifida, or its more severe form, mild meningocele, is the most common central nervous system or neurologic birth defect in the world.
Mild meningocele is a defect in the spine. It's failure of the spinal cord to close.
The spinal cord, or the neural tube, as the embryologists say, forms very early in gestation, certainly before 8 weeks gestation. And Spina bifida is thought to be a failure of the formation and closure of that neural tube, so that the spinal cord elements are exposed to the intrauterine environment.
It's a progressive process. It's a progressive injury, so that by the end of pregnancy, there's been direct traumatic injury to the spinal cord, and there's been injury from the amniotic fluid itself.
Because of changes in pressure and fluid flow, babies are also at risk for developing hydrocephalus.
Which is a fluid buildup on the brain and which damages the developing brain.
Virtually every child with myelomeningocele or spina bifida has neural Chiari malformation on X-ray. And what it is that the back part of the brain, called the cerebellum, has a lot to do with control of motor movements, is wedged down into your neck.
The cerebral spinal fluid that cushions the brain and cushions the spinal cord leaks out through the back, through the open spina bifida defect. That leads to the back part of the brain getting sucked down into the upper part of the spinal canal. That in turn can block the circulation of cerebral spinal fluid in the brain, because the fluid is produced in the brain and then there's no way for it to circulate beyond that blockage point.
So if there's a blockage in the flow of that fluid, then the water builds up inside the ventricle. So you've probably heard the term water on the brain. The water isn't on the brain, it's inside the brain. If you don't treat that, then you end up with a massively enlarged head, you die, or you end up with severe mental retardation.
So in order to minimize that ongoing damage, fluid, the pediatric neurosurgeon places a shunt tube.
It's a simple device. This is a shunt. It's made out of silicone. This end goes through a hole in the back of the head into that water cavity and tunnels down into the skin and goes into the abdomen, which is able to absorb the fluid. It's not a cure. It treats the symptom. It doesn't treat the disease.
Once you have a shunt, there are multiple complications that can arise from it.
The shunt can become infected, which is a serious complication, because then the brain and the layers of the brain can become infected with meningitis and encephalitis. And with each bout of infection, that can affect the brain function.
And then, of course, there are mechanical problems. They clog, they break, they get to be too short, they migrate.
So it's not unusual for a child with spina bifida who has a shunt to require that shunt, and not only for life, but to have that shunt changed at least 5 or 6 times during the course of their life.
It's important for parents to understand the potential complications or ramifications of spina bifida after the diagnosis is made.
A child may experience difficulty with apnea, forgetting to breathe. They may also have breathing problems, choking, blue spells.
In the worst case, you end up with a child's on a ventilator with a tracheostomy and tube in the stomach to eat. And that is a huge impact on your quality of life.
Spina bifida can cause paralysis in the lower extremities that can interfere with the baby's ability to walk, or they may even be wheelchair dependent.
They also have difficulty with their bowel and bladder function.
Most of these kids, when they become older, have to catheterize, or else they have to wear diapers.
They can develop significant curvatures of the spine because of instability, bony instabilities of the spine if they have a high lesion.
Because of the lack of innervation to the feet and the ankles, there can be the formation of club feet, or the medical term is talcus, as a consequence. So that requires orthopedic intervention after birth.
And then there are problems that can come on later on in life. It's not even necessarily done when you're a baby. You can get tethered cord, which means that the nerve tissue gets caught up in scar tissue and you can lose function. So it's a lifelong issue of disability.
That's an ethical question to ask, but they are not going to tell you to abort your kid unless it's going to kill the mother. That's up to the parents to decide that. And those doctors dedicate themselves to saving lives. Their entire education is to assume that this patient is going to live. They want to live, and they're going to operate on them and improve their quality of life as much as possible. So that question of eugenics is not part of our modern medicine cycle, really. So, and in this case, you can see that a lot of times this will cause paralysis to the legs, to the body. Sometimes you can see this if it's up high in the neck, the everything kind of fuses. So you'll see these people walking around like with a big, with big scat, with like big traps on the back, like locked in place. That usually is a result of the scar tissue and everything that has built up there. And the kind of surgery you remember, think about if you're working on an infant, you have very little room to have any leeway through there. So it's an absolute precise job to work in. In some cases, they do that in utero. They'll have infants that they're working on, not normally for spina bifida, but for congenital heart defects or lung concerns. They will work on infants as they expose the mother, open up her belly, get into the uterus, cut through the uterus, find the infant, open up the amniotic sac, and operate on the kid that way. You can see that was kind of a hell of a job there. So what they're saying is you can get the cord will catch on the scar tissue, and then as you're moving around, it won't allow you, it might do damage to that portion of the nerves. It might cut off circulation or movement down the body, sensation of movement down the lower portion of the extremities. And of course, it can come with mental retardation as well. If that has a herniation significant enough in the brain to smash everything through there, and then to cause swelling in the brain, chronic swelling, especially in utero, that's going to leave lasting damage to the body. So it's rough. It's a really difficult thing. My hat goes out to doctors and people that dedicate their lives to trying to do some good for people. And a lot of times this is like third world. They don't see it because they're not in sonograms. They're not doing any, what do you call it? Prepartum assessments, diagnostics and things. It's found after birth. Yeah, bro. I don't know. I don't know. I believe it's the idea that they have been, latex was exposed to them as an early onset infant, and they build antibodies to that. I think that's the reason behind it. Very wild, though. That's weird, huh? Yeah, I think that's probably the reason, is that they're exposed to latex very early, and it causes antibodies to grow at an early period of time. And then it stays with you. So let's look at shunts. Shunts are like what they mentioned. They put a tube into from the brain, that there's that little area in the middle of the brain called the ventricle. And it's a space where the cerebral spinal fluid is made. It's where the chemoreceptors that measure oxygen and carbon dioxide reside. And there's a flowing of that cerebral spinal fluid around all of the different parts of the brain. And it will build up because of the blockage of the cerebellum, so that you aren't going to be able to release the abundance of cerebral spinal fluid. Remember, with children, the head is very malleable. It hasn't fused yet. So you'll show up and find these kids and their heads are, larger than an infant's head, and sometimes 2 sizes bigger than an average infant's head. And that's because the brain, and as everything swells, the pressure builds, it actually will cause the skull bones to get larger and splay out, get bigger. So that's what we call water on the brain, or hydrocephalus. Hydro like water, cephalus like cephalic is usually brain or something that refers to the head, like a cephalopod. Anybody eat abalone? Abalone is a cephalopod. It's a head with a foot. Yeah, anyway. So when it gets blocked, the head will swell. And if an infant's head is not made of bone yet, the head itself will actually grow in size. And then you get an increase of cerebral spinal pressure. Here you go. So this is just basically, you take a shunt, that's a tube, and it runs from the head safely out the back of the head, and it just dumps it into the peritoneal sac, just right into this, into the between the abdominal organs. Yep. It's placed surgically into the brain. Yeah, they go in, and I'm not sure exactly where they start it, but when they go, they get it into the cerebral ventricle, and then they feed it down the neck or spinal column, usually like next to the vertebrae. You don't see it, but it's inside there, and they'll feed it down and then make a hole in the peritoneal cavity and place it in there. And it's kind of a one-way shunt. As ever the pressure builds up, it just like a percolator drops a bit back into the stomach, and that gets reabsorbed into the body. They get blocked. Patients begin to have intracranial pressure begins to increase. You see things like altered mental status, nausea, vomiting, potentially unequal pupils. Usually seizures are common with that. So whenever you hear of a patient having a shunt and you're dealing with some neurologic changes, consider that shunt is no longer working, either through some of the things with dope. It either gets blocked, or it's kinked, or there's a hole somewhere in the continuity of it. Something's happening to that. So 10:20 a.m., your dispatch will have an 18-year-old girl whose parents state they cannot arouse her from sleep. Home is clean, no obvious evidence of trauma or violence. On the scene, mother tells you that her daughter, Bonnie, has a history of spina bifida. Okay, so you're thinking to yourself, spina bifida, it's got a whole brain, stuff comes out the back and the neck. Okay, causes deficits, possibly mental retardation. All right, she has a long-standing problems with excessive buildup of cerebral spinal fluid in the ventricles of her brain, and has a ventricular peritoneal shunt in place since she was 1 month old. Patients found in bed. She's snoring, respirations 10 a minute. Is that good? How old is our kid? Okay, 10 a minute. Is that decent for an 18-year-old? Little slow, but it's not. We need to bag valve mask this patient, right? Somewhere around like 6 to 8 would be when we'd have to intercede with mechanical ventilation. All right, but it's slow. You're right. No evidence of blood or secretions in the mouth or nose. She opens her eyes to pain, but then closes them as the stimulus is released. She mumbles when she speaks. So let's do a GCS on this patient. You know your GCS? Glasgow Coma Scale? Ooh, baby. You can get a maximum of 4 points on the eye opening. You get a maximum of 4 points on the eye opening, 5 points on the verbal ability, and 6 points in terms of motor. You remember this? Okay. So if she opens her eyes to painful stimuli, that's a 2 actually, because remember, you can get a 1 for nothing. Even somebody who's dead gets a GCS of 3. So it's basically the AVPU. If the eyes are open, you get 4 points. If they open to voice, you get 3 points. They open to pain, you get 2 points. If they don't open at all, you get 1 point. Okay. Then speaking, you can get 5. Confused, I don't know where I am, you get 4. If they're making unusual, not making sense at all, you get 3. They're making noises and sounds, you get 2, and no noise at all is 1. So where are we on this patient? She mumbles when she speaks. Sounds like a 2 to me. Sounds like a 2 to me. So we're so far at 4. 4. All right. Skin's hot, moist. What's that tell you? Yeah. And what about the heat? What potentially is an issue? Fever. Yeah. Anytime you see hot fever, like think it's an infection. Radial pulses are present, equal, and remarkably strong. Ooh, why would they be strong? High blood pressure. Great. Remember, high blood pressure, as the blood pressure increases, the pulse rate slows down and it bounds. You feel that like boom, boom, boom. Pulse rate is 60 and it's on the slow side. So that would make sense that we're dealing with increased intracranial pressure. There she is. Dunzo. Not feeling too hot. How would you describe Bonnie's primary assessment? She's severe. Is this load and go? Yeah, for sure. Fluid behind the ears. Oh, so this is gonna be in, you guess, I would check behind the ears and look to see if we see anything coming, leaking out. But this is probably, unless there's been trauma, they fell down, it would break and bleed. In which case, that could be very much the case. You got a big swollen water balloon, and the slightest smack or bang can cause that to burst. But all of this is inside the dura mater. It's in the leather sac. So it still hasn't come out of the, it's still like encased in that surrounding package. So it probably won't be leaking out of the ears, behind the ears. Possibly. Oh, for the shunt? Yeah. Okay, is that what you're talking about for the shunt, not for battle sign? Yeah, you could see if it begins to swell up. Sure, you can see the shunt. Take a look at the shunt. Yeah, see if you can see it subdermally. You know, take a look and see what you can tell on the shunt. Is that also warm and hot and spongy or swollen? So, did we get any motor skills for the patient? She didn't do anything, but let's say that she rolls away from you when you're touching the patient, when you're grabbing her and moving her around. She just kind of rolls away. So remember, with the motor portion, it's you instruct them to do something and they can follow your direction. They stand up and they walk over and sit down on the gurney. That's a 6. 5 would be if you are causing tactile stimuli, they grab your hand and move it out of the way. 4 would be if you are causing an uncomfortable pain or tactile stimuli, they withdraw, they roll away from it. And then 3 refer to these coma-like responses that occur when someone is in a coma or becoming comatose, or they have head trauma, which is they flex. The flexion is at 3. Basically the fetal position. You just the whole body goes into the fetal position. The one less than that is extension, and the whole body actually, instead of coming down towards the core, everything goes out like that. They used to call towards the core decorticate, and they would call the extension out decerebrate. They decerebrate when they have painful stimuli. And I've never seen that. A friend of mine did see decorticate and decerebrate, flexion and extension. One time the patient had a head trauma and they were working on him, and the patient like suddenly went into the core like that, and then flatlined and died. So don't wait to see those things. But in this case, we'll say the patient rolls away from you. That would be 4. So we're dealing with 8. Is that right? Okay. Normal child who works a part-time job. So we know mentally she's with it. She didn't have any deficits due to the spina bifida. Busing at local restaurants, full life spider health challenges. She has a history of learning disabilities and physically awkward due to poor muscle. Don't we all? Anyway, lower extremities, which, well, I mean, normal kid, thankfully, you know what I mean? Like, it's nice to see. A problem which leads to falls is the loss of muscle control. Okay. Frequent headaches for sure. Against the patient's objections, Bonnie went camping with friends over the weekend. Arrived home late last night complaining of headache. Parents said she seemed flushed and irritable and went straight to bed. What are you around a lot when you're camping? I mean, nothing specifically, but obviously dirt and junk and crud, and you're not showering regularly, and very easily that could cause some kind of infection. State there's not unusual. It is not unusual for her to be irritable and retreat to her bedroom when experiencing headaches, but they allowed her to sleep in today, and when they became worried when she didn't wake up at 10 a.m. Called 911 after that. Spina bifida, seizures, migraines, scoliosis, all results of the spina bifida. Seizures, increased trauma, head pressure. Seizures are likely. Migraines, of course, scoliosis due to the way that the back was repaired. She takes Imitrex, Dilantin, seizure meds, no allergies. Last oral intake, saltines and chicken soup. Okay, blood pressure. What does that tell you? Really high. Pulse is very slow. Respiration's irregular. Setting 93, which is low. You can give oxygen. And the blood glucose at 95 within normal limits. Okay. Lungs are clear. Good. Pearl. Lump behind left ear. Here you go, Daisy. Look at that. Nailed it. So what's that telling you? Shunts building up, backed up, obstructive. Say what? Head, ears, eyes, nose, throat. Facial, no facial droop, no, I don't know how you would tell. You can, I guess, just look, but no oral trauma, no head trauma, lungs clear, chest rise, mild sideways curvature of spine. That could be normal, that could be new. Soft, non-tender pelvis, not distended, incontinent to urine, meaning they're unconscious enough that you're not regulating your bowels and your involuntary muscles, not bowels, but your bladder. Extremities, CSM times 4, no pedal edema, open wound with a drainage to right calf. Oh no. So somebody had an infection, maybe. What do you think? How does this? So they have a gash in their leg and it's seeping pus. Sounds like. How could that cause an issue to the brain? Infection. What did you say? Water microbes. Okay. Meaning that what? The water got into the cut? And then from there, where does the infection, how does it get to the brain? Yeah, just bloodstream, just regular old getting into the bloodstream, going through your circulatory system. Eventually, that gets to your heart and gets pumped to the rest of your body. That bacterial or viral body got into the brain through the blood-brain barrier, where the blood and the cerebral spinal fluid intermingle. And very few things, a lot of things can't get through there. A lot of them can. Some drugs can get through, some can't. Some viruses can, some viruses can't. In this case, it sounds like whatever it was passed through the blood-brain barrier, which is basically like another osmotic, like a filtered area. Don't sweat it too much if it's not really that necessary for EMTs, but it's nice to know. It's like another diffusion ability where the blood vessels and the different tissues come together, and then in order for anything to get past, they have to diffuse across or go through by osmosis into the cerebral spinal fluid. And so there's this change in between blood and brain and cerebral spinal fluid that is supposed to, it gives you another added layer of protection, but not in this case. Any additional interventions you would like to perform? I mean, again, we have, all right, so we have something going on that's pretty profound, pretty bad. We've worked through physiologically, potentially what's happening. The infection got from the leg through the bloodstream to the head, crossed the blood-brain barrier. Patient's now having like a septic reaction with some kind of swelling in the head and potentially a blocked shunt. Probably it could be like pus or, chunky stuff stuck inside that and is blocking the flow. So in our job as EMTs, what are we going to do? Oxygen, rapid transport. Okay. Did you have something? What else? Anything else you would add to that? What would be the position of comfort? Yeah, maybe laying down. I mean, if they're unconscious, theoretically, we should have them laying flat so that if they're losing blood to the brain, you want them at least being horizontal so the blood can make it to the head rather than have to fight gravity to get to the top. Now, in this case, patient's blood pressure is going to be decent enough that you could put them up because this patient's blood pressure is 200 something. So we could, if it's easier, work with them with the head up. Also, in one case, if we give high flow oxygen, it might cause some vasoconstriction. It might bring the blood pressure. Well, not really. Yep. Right. It could cause, like, you could get an aneurysm, you could cause stroke, you could have seizures, potentially you do some damage to the midbrain. Did you, who had a, well, yeah. Can you take off clothes? Yes, absolutely. Yeah. Remove additional clothing that's keeping them febrile. Can we fix the obstruction in the shunt if there is one? You can't do anything about it. That's again where you just say, well, we've done everything we can. We've provided for ABCs. We've loaded them. Let's go. That's all we can really do, which is, it's reassuring as EMTs. Like, if you get to the worst case scenario, you just go, well, all right, well, let's make sure that we just manage airway, breathing, and circulation. And we just do that all the way to the hospital, but let's go to the hospital really fast. And that's all you need to do. The last thing, obviously, make sure you call the hospital and tell them you're bringing in a bad off patient. You're bringing a critical patient in to them so that we can manage it. Okay, how we doing? Do you want to take another break, or should we keep it rolling? Another break? Keep going? All right, well, let's go through these little guys. These are cool, and then we'll take a break. The left ventricular assistance D, or the LVAD, is the cure to what we have decided to do for hearts that are, they've had a heart attack so bad that a massive portion of the usually left ventricle is scarred over. Heart's not going to work whatsoever. You know, we have this nice flexible muscle that beats super efficiently. If a large portion dies, it just becomes scar tissue. And I don't know if you've seen large scar tissue. It is in no means flexible, spongy movement, and it doesn't have an ability to contract like the heart muscle does. So let's say we have a big dead spot that's scarred over in the heart. How's that going to affect your efficiency pumping? You're donezo. It's bad news. Your heart's basically just trying to beat around a big broken, scarred over, graft on there, and it doesn't work well at all. And basically, this is what congestive heart failure is on a massive level. A huge portion of the heart has died. So to actually beat, it's just like there's a portion of it that won't work now. It's just a dead tissue. And that's usually what we're talking about with congestive heart failure, is a portion of the heart dies and renders the heart less functional, renders the heart with less strength and ability to perfuse the body with decent, adequate enough contractions. So doctors have always said, how do we build an artificial heart? You remember in RoboCop? I always remember when I was a kid, when in RoboCop, there's a commercial of Yamaha is making an artificial heart. And I remember thinking, like, yeah, I guess we can build artificial hearts. I was way too young to be watching RoboCop, by the way. It's a gnarly movie. We do use that. So we will use bovine or pig valves to fix those different AV valves or the semi-lunar valves. But aside from that, you can go through and do work on this heart, but we were really limited to keeping the patient on their own heart. You can put pacemakers, defibrillators, but you're still rendering the heart basically as useful as you can, like, soup it up with mechanical devices. So they were trying to build the hearts that beat, that would pump, and takes a lot of work. It's a lot of moving parts. It's in no means as effective as the regular human heart. And it's using a ton of energy, of electricity to do so. So they were just nowhere near getting a mechanical beating heart that they could use to implant. And then somebody said, well, why does it need to beat? And that's a good idea. That's a wonderful question. I never thought of that. So this is basically like a fire engine water pump. It's a centrifugal pump. It spins, and the spinning allows it to change the pressure as the blood gets inside and out of it. It doesn't blow the tube lines, which maybe you'll learn in Fire 1 on 10 why that is. Building a pump for water is a major issue because you have water hammer. and it'll blow the pipes and it'll bust the pump. So if you create a centrifugal pump, you can send water out, water can back up, and it just gets in the flow of everything. This is just a centrifugally spinning fan system. It takes the blood in from the left atrium and the left ventricle, spins it up, and circulates it out to the body. So it's bypassing the aorta, and it's sending blood throughout the body, or maybe it bypasses a large percentage and then reattaches somewhere in the aorta. So when you go on these patients, what are these patients not going to have when you check them? Yeah, no heartbeat, no pulse. You may hear a heartbeat. It may be in there, but it's not doing the job of the LVAD. The LVAD is circulating the blood around. Yeah, you're not, these people are not going to be runners. They're not going to be active. There's no ability to speed it up and slow it down according to your body's oxygen and perfusion demand. So these patients are basically in bed, maybe if not bedridden, limited to light physical lifestyles. Yeah.
The heart has 4 muscular pumping chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. The left ventricle pumps blood out through a large artery called the aorta to supply the body with the oxygen and nutrients it needs. In left-sided heart failure, the left ventricle is not able to pump enough blood to the body. The 2 types of left-handed heart failure are diastolic, where the left ventricle can't relax enough to fill with blood, and more commonly, systolic, where the left ventricle can't contract strongly enough to push blood to the body. In severe or end-stage heart failure, the heart is getting weaker and doesn't respond to medication. For left-sided end-stage systolic heart failure, a doctor may recommend an implantable left ventricular assist device, or LVAD, to help the heart pump enough blood to the body. An LVAD is a small mechanical pump implanted inside the chest or abdomen that takes over the job of the weak left ventricle. Blood flows from the left ventricle through an inflow tube to the pump. The pump pushes the blood through an outflow tube into the aorta. From here, the blood travels normally from the aorta to the rest of the body. A cable, called a drive line, connects the LVAD pump inside the chest to a control unit located on the outside of the body. The control unit is a small computer that controls the functions of the pump and alerts the patient if there are any problems. The pump and control unit receive power through a cord connected to a battery pack. Finally, the control unit and battery pack are held in a lightweight patient pack. An LVAD may be a temporary treatment until a heart transplant can be performed. Or, if the patient isn't able to have a heart transplant, an LVAD may be used for destination therapy, which is long-term treatment.
Very cool. So,
The Impella is the world's smallest heart pump.
Impella, it refers to the idea that there's a propeller, or inside something like a turbine, a propeller inside that is called a impeller. So basically, that's how that thing is swinging and moving. What happened to the? Okay. All right, let's take a break. Another 10 minutes.